Yes.
Dr. Shirley, as far as you can recall, how and when did you become aware that AIDS might be transmissible by blood or blood products?
As far as I can remember, it would have been about 1983.
Were you aware or did you see the reports that came from the Centre for Disease Control in July and December 1982 reporting cases of AIDS in haemophiliacs and in transfused patients?
No.
Now, if we could have up on screen, please, PRSE 302410. This is an article from the New England Journal of Medicine in January of 1983. It's one, I think, of 3 articles in the course of that month on this issue. This particular one is the 13th of January. It's called AIDS and Preventive Treatment in Haemophilia. And if we could go to the second page, please, Shomik. And zoom in on the last paragraph in the left-hand column, so the bottom of the left-hand column. You'll see here that the author says this: the fact that haemophiliacs are at risk for AIDS is becoming clear. If the use of cryoprecipitate will minimise this risk, the current home infusion programme needs to be revised. And then it talks about the data being consistent with a greater potential for AIDS in the population treated with concentrate. Physicians involved in the care of haemophiliacs must now be alert to this risk. Preventing the complications of the present treatment may have to take precedence over preventing the complications of haemophilia itself. Do you recall whether you saw this at the time in January 1983 or later in the course of 1983?
I wouldn't have done because I didn't read that journal.
There were various reports in the ordinary media, I think New Scientist in January and February 1983, of concerns about the AIDS and possible risks to haemophiliacs. I won't take you to the details of them, but do you recall whether you saw any of those in early 83?
I don't remember.
Shomik, could we then go to HCDO 40/517_001? Now, this is a letter sent out by UK-HCDO. It's from Dr. Krask, Dr. Ritzer and Dr. Bloom, sent, as far as we understand, to all haemophilia centre directors, dated the 22nd of March 1983, about AIDS. And it circulates papers and refers to setting up of a system for the reporting of possible cases. And if we go to HCDO 40/517_002, please, Shomik. This is a report we understand to have been circulated with that letter, Dr. Shirley. It's from Dr. Krask, dated the 1st of March 1983. And we can see it provides information about cases of AIDS. If we go to the second page, we can see towards the middle of the page, it provides information about high mortality rates. And then if we go to the third page, please, Shomik, we can see under the heading etiology, there's a discussion about theories that have been advanced. The first is drugs, and that's discounted. The second is the immunosuppressive effect of cytomegalovirus, and Dr. Krask says that seems unlikely. And then if we go over the page, reason 3, it is an infectious agent with a similar epidemiology to that of hepatitis B. And Dr. Crass goes on to say in the following paragraph, if 3 is the most likely cause, then it's possible that such an agent might be present in the plasma pools used to prepare commercial factor 8 and 9 concentrate, manufactured from donor plasma collected in the USA. Do you recall receiving this letter with its enclosures in March of 1983, Dr. Shirley?
No, I don't.
If you did receive it, and as I say, our understanding is the intention was it was sent to all directors, would you have read it at the time?
Yes.
Is it possible that this was the basis for your developing understanding of the risks of AIDS from blood products in the course of 1983?
Probably.
If we then go, please, Shemik, to HCDO 40-270_004. You'll see, Dr. Shirley, this is a letter dated the 24th of June 1983. If we go to the second page, we can see it's authored by Professor Bloom and Dr. Ritzer. Go back to the first page, please. It's headed AIDS. It refers to a meeting of reference centre directors held on the 13th of May 1983 to discuss this problem in haemophilia, its implications and our recommendations. It refers to one possible case having been reported. And then it says this: at the above-mentioned meeting on the May the 13th, the following general recommendations were agreed. 1, for mildly affected patients with haemophilia A or von Willebrand's disease and minor lesions, treatment with DDAVP should be considered because of the increased risk of transmitting hepatitis by means of large pool concentrates in such patients. This is in any case the usual practice of many directors. 2, for treatment of children and mildly affected patients or patients unexposed to imported concentrates, many directors already reserve supplies of NHS concentrates, cryoprecipitate or freeze-dried, and it would be circumspect to continue this policy. It was agreed that there is as yet insufficient evidence to warrant restriction of the use of imported concentrates in other patients in view of the immense benefits of therapy, but the situation will be constantly reviewed. And then it goes on to make some further points. Now again, our understanding is this was sent to all directors. Do you recall receiving it?
I don't.
If it was received, would you have read it?
Yes.
Now, if we look at paragraph 1, you'll see there that the recommendation is to consider DDAVP for mildly affected patients with haemophilia A or for patients with von Willebrand's disease. Can you assist us with whether that was, by this time, June 1983, your policy at Frimley Park?
I can't put a date on when I started using DDAVP. I just know that I started using DDAVP for von Willebrand's disease patients and mildly affected haemophilia patients as soon as it became a recognised treatment. So I think I would have been using it at this time, but I can't say categorically that I was.
Would you agree that if you weren't by then using it, that on receipt of this letter, your policy should have changed so that DDAVP became the first line of treatment for such patients?
Yes.
In terms of paragraph 2, treatment of children and mildly affected patients or patients unexposed to imported concentrates, the recommendation there is that it's circumspect to continue with a policy of reserving supplies of NHS materials. It doesn't distinguish between cryoprecipitate or concentrates, but refers to both. You didn't, as I understand your earlier evidence, have any such policy because you simply depended upon what Tooting provided by way of concentrates. Did you, on receipt of this or at any point in 1983, consciously shift away at all from commercial concentrates at least for the treatment of children or previously unexposed patients or mildly affected patients?
My recollection is that I used cryoprecipitate as first-line treatment for these patients.
But you don't recall receipt of this recommendation leading you to have any conversations with Tooting to try and avoid them sending you commercial concentrates?
No, I don't.
If we then go to PRSE 304440, please, Shomek. You'll see, Dr. Shirley, these are the minutes of a UK-HCDO meeting on the 17th of October 1983. And if we go to the second page, please. And we look towards in the second half of the page, if you follow it down alphabetically, we can see that you were in attendance at that meeting. And as I understand it from your evidence and from looking at the minutes, this would have been the second meeting you attended. You'd attended in 1981. You didn't attend in 1982 for the reasons you've already explained, but you attended again in 1983. If we go to page 10, please, Shomek. And we look at the second half of the page under the heading Any Other Business. You can see there the record of a discussion. Dr. Chisholm raised the problem of patients refusing to take up commercial factor VIII concentrate because of the AIDS scare. She wondered, in view of the worry of the patients, whether the directors could revert to using cryoprecipitate for home therapy. Professor Bloom replied he felt that there was no need for patients to stop using the commercial concentrates because at present there was no proof that the commercial concentrates were the cause of AIDS. Dr. Chisholm pointed out that there was a further problem in her region because of problems in getting large amounts of commercial concentrates, whereas she could get unlimited supplies of cryoprecipitate. Other directors reported they'd had the same problems. After discussion, it was agreed that patients should not be encouraged to go over to cryoprecipitate for home therapy, but should continue to receive the NHS or commercial concentrates in their usual way. Do you recall that discussion at all?
No, I don't.
If we go to the next page and we look at the paragraph number 10 under the heading Current Situation Regarding AIDS, Dr. Krask is reported to have presented a paper. And then if we look a few lines down, it says there was some discussion regarding the 2 cases of AIDS in haemophiliacs in the United Kingdom, and Dr. Scott gave details about his case, and then there's further discussion about forms and documents and steps that Dr. Krask was going to undertake. Now, Dr. Scott was the director in Bristol, and the case he was describing was the case of a haemophiliac patient in Bristol who by this time had died of AIDS in the weeks or couple of months preceding this meeting. Do you recall that?
No, I don't.
Do you recall learning anything at all about either the first case of AIDS in a haemophiliac patient, which was a Cardiff case, or this second case, a Bristol case? Did you recall learning about that at all?
No, I don't.
Now, this was autumn of 1983, and it may be reasonable to think that the risks of AIDS would have been a key topic for discussion amongst haemophilia centre directors at this meeting, not just at the formal minuted sessions, but in the informal conversations that directors might have had. Do you recall anything about any discussions you had in relation to AIDS at that meeting?
No, I don't. It was such a long time ago, and as I've said before, the haemophilia side of was a small proportion of my workload, and to be able to remember what discussions I had at meetings 40 years ago is impossible, I'm afraid.
Did you take any proactive steps in the course of 1983 or 1984 to keep up to date with developments about the risks of AIDS? for what may have been a very small number of your patients, but was nonetheless the risk of a very serious, probably fatal illness?
I don't remember taking any proactive steps to keep up to date. Obviously, I would have had the information from the Haemophilia Centre Directors Organisation meetings and minutes, and I'm sure at that time that at meetings of the Royal College of Pathologists or the British Society for Haematologists, this is a subject that would have been discussed, and I attended those meetings whenever I could.
But you don't record anything about any particular, the content of any particular discussion?
No, I'm sorry, I don't.
If we then go to HCDO 40394_117, please, Shomik. Now, these are notes of a meeting of the reference centre directors at Elstree on the 10th of December 1984, and we can see that those attending included Dr. Kernoff from the Royal Free, Dr. Ritzer from Oxford, Dr. Savage from St Thomas's, so 3 of the reference centres that you had dealings with. Were you aware that such a meeting was taking place?
No, I wouldn't have been aware unless it had been mentioned in the previous minutes of the general meeting of the directors.
Were you aware that by this time, by the 10th of December 1984, it was known that patients in Edinburgh treated with NHS concentrate had been tested positive for HTLV3?
I think the only thing I was aware of at that time was that the vast majority of haemophilia patients who had become positive for HIV had received commercial factor, but that there were one or 2 patients in the country who had seroconverted after receiving NHS factor.
Do you consider that the fact that a whole cohort of patients in Scotland have been infected as a result of, or seemingly as a result of, treatment with a Scottish NHS product, that should have been immediately notified to directors such as yourself who were not reference centre directors and not privy to the internal discussions going on within UK HCDO?
Yes, it should have been. To be honest, until what you've just said, I didn't know that a whole cohort of patients had been infected from a Scottish blood product. This is the first I've heard of it.
Did Dr. Savage, Dr. Ritzer or Dr. Kernoff or any of their colleagues at the 3 reference centres with whom you had dealings, Oxford, St Thomas's, Royal Free, did they at any time in December or December 1984 or early January 1985 after this meeting make contact with you, who you were dealing with some of their patients, to pass on to you what had been discussed at this meeting?
No, I don't think so.
If we look at HCDO 40270_007, this is the document that was produced following the meeting on the 10th of December. It's called AIDS Advisory Document, and as you know, it's dated the 14th of December 1984. Do I understand correctly that this is a document which you did receive, but you don't think you received it before Christmas 1984?
I can't say definitely that I did receive this document, but I can't imagine that I did not receive it. I think it's very unlikely that I would have received it before January 1984, given the fact that it would have been put in the post, and then we're looking at Christmas and New Year. So it's unlikely that I would have read it until January.
Just a point about dating. I think you mean January 1985.
Yes, sorry, I do. January
yeah.
1985.
And while on dating, if I may just raise one point in case I've misunderstood. You mentioned the knowledge of the Edinburgh outbreak. It didn't break in the press until the 20th of December.
That's right.
Just so that I make sure that I've got that right. There was no other way of knowing of it except by the internal grapevine, presumably.
Presumably. We explored, obviously, with Professor Ludlam and his evidence in December, when he became aware,
yes.
Late October, early November, the meetings and discussions that took place, and then we had the meeting on the 10th of December.
Yes, he knew.
Yes, and others knew.
Yes.
Precisely who knew is a matter that we may need to explore further. But you're absolutely right, sir. In terms of a press publication in the national media, it was the 20th of December.
And it was exactly that led to the meeting on the 19th, about which we've heard quite a lot of evidence.
In Edinburgh, yes.
I'm sorry for that interjection.
I think it may follow from the answers you gave earlier, Dr. Shirley, that you didn't see the press reporting on the 20th of December, which reported the infection of patients in Edinburgh.
No.
Now, if we just look at this document, we can see it says, under the heading background, in the UK there have been 102 cases with 3 reported haemophiliacs. No doubt other cases are developing in the haemophilic population. And then if we go over the page, we can see at the top of the page it says, it seems probable that HTLV3 has been incorporated into at least one BPL and one Scottish batch of factor 8. Recipients are being followed up. And then if we go to the bottom half of this page, please, Shomik, we can see options in probable decreasing order of safety from AIDS for haemophilia A. 1, heated UK concentrate, note still NANB hepatitis risk. 2, single donor cryo or FFP. 3, heated imported concentrate, note still NANB hepatitis risk. 4, unheated UK concentrate. 5, unheated imported concentrate, almost certain to be contaminated. So in terms of the safety, imported unheated concentrate, the least safe, but next least safe is unheated UK concentrate. And then if we look at the recommendations, 1, concentrate still needed. 2, use DDAVP in mild haemophilia A and von Willebrand's if possible. And then if we go to the top of the next page, 3, for haemophilia A needing blood products, A, virgin patients, those not previously exposed to concentrate, and children, use cryo or heated NHS factor 8 if available. B, severe and moderate haemophiliacs previously treated with factor 8, use heat-treated NHS factor 8 if available, or heat-treated US commercial. Now, as far as you can recall, once you had received this, and assuming, as I think you accept is likely that you did you then adhere to its recommendations and cease using unheated NHS or commercial concentrates?
I can't say whether I did or not. I can't remember. I do know that further on into 1984, I was using the 8Y product.
I think you mean 1985.
Oh, 85, yes, sorry.
Do you agree that what we see set out here, in particular, the fact that HTLV3 had been incorporated into NHS product, the options in decreasing order of safety and the recommendations, those are key matters which any haemophilia centre director would want to know about as soon as possible.
Yes, and I always followed the guidelines that were relevant at the time. So once I had received this document, I think I would have followed the recommendations, but because I can't remember, I can't say definitely that I did.
And in terms of the materials that you received from UKHCGO in 83 and 84, there are minutes of meetings, there are the letters that we've looked at, and then there's this. Were they always only sent by post?
As far as I can remember, because we didn't have any computerization for sending this sort of document. And I can't remember when fax machines came in. Once fax machines were in the laboratory, we would have received these documents by fax, I think.
Do you accept that as a matter of principle, once in, let's say, the spring of 1983, that you'd become aware from the UKHCGO materials that we've looked at that there was at least a connection between use of blood products and risk of AIDS? Do you accept that patients should have been told that?
Yes, I think they probably should have been told that.
Did you tell your patients that you were treating in the course of 1983 and 1984 that concentrates might carry a risk of AIDS?
I don't recall telling patients that.
Do you accept that was wrong?
It's wrong by today's guidelines and thinking. It's very difficult looking back 40 years to say that what happened then was wrong in the light of today's knowledge and what we do today.
You've described a paternalistic approach, and you're not the first witness to by any stretch of the imagination to have done so. But nonetheless, it was still, was it not, the case even in the early 1980s that there was a concept of informed consent. Patients should be given some information about the risks of treatment, even in the 80s.
Yes, I think they probably should have been.
And of all the risks that you're going to spell out to a patient, isn't the risk, even if you think it's a small one, isn't the risk of contracting a disease known to have a very high mortality rate, poorly understood, no real known treatment, isn't that the kind of risk that it's most important to spell out so the patient can decide for themselves if they wish to run it?
Yes.
Just returning then to the topic of the use of heat-treated products in the course of 1985, Dr. Shirley, can we look at BPLL 0002371_034. We can see that this is a letter dated the 5th of February 1985, written by you to Dr. Snape at BPL, in response to a letter from Dr. Snape dated the 24th of January, and you're asking for heat-treated BPL product for a haemophiliac child, according to BPL's protocols. Can you recall whether at this time in early 1985 you were only using heat-treated concentrate obtained from Dr. Snape in the way we see here on a named patient basis? Or did you start receiving heated commercial concentrate from Tooting as well?
I don't know whether we were getting heat-treated commercial concentrate from Tooting as well.
Well,
Sorry, excuse me, could I go and get a glass of water?
Yes, of course.
Thank you. Sorry, I forgot to bring it back with me after our break.
Don't worry. Anytime you want or feel you need a break, just ask.
Okay, thank you.
I was going to observe that your answer, I think, was in respect of commercial concentrate, heat-treated commercial concentrate. This is asking Dr. Snape of the Blood Products Laboratory for heat-treated factor VIII concentrate. Presumably, given his position, that will be NHS. Do you think?
Yes. Yes.
Thank you.
I think from your earlier answers, you're not able to say one way or another whether in the course of the first part of 1985 you continued using unheated concentrates.
Given that directive from the Haemophilia Centre Reference Directors Organisation, and knowing that I have always tried to follow guidelines, I think I probably would have, where at all possible, given heat-treated products. What I can't say is whether I was always able to get heat-treated products from Tooting, or whether they were still supplying my blood transfusion department with any NHS unheated products.
And then if we go please to BPLL 0010362. This is a delivery note signed by you receiving a consignment of what I think is probably by this time 8Y. It's dated or it's dispatched on the 8th of October 1985. It's in respect of 5 patients. And then it says this, 2 paragraphs under the box where the patient's names have been redacted. The physician should assess and record the efficacy of at least the first infusion of this product received by each patient, take blood samples for tests of HDLV3 antibody, and undertake follow-up for possible infection with hepatitis viruses.
Sorry, I can't see where that is.
So if you look at the box where there are names redacted.
Yes.
And then the next paragraph begins to breathe. Thank you, Shomik.
Oh, yeah.
So then it's the second paragraph there. The physician should assess and record.
Okay. Thank you.
So is this describing the trial or study of 8Y in which your patients were participating and you were participating?
I don't know. I've not seen the study trial protocol, so I don't know whether this batch of heat-treated NHS product was sent to me for patients in the trial, or whether it was sent to me for other patients.
But we can see you're being asked here to take blood samples for tests of HDLV3 and undertake follow-up for possible infection with hepatitis viruses. Did the patients who you were treating with this product, did you explain to them that you would be taking samples for tests of HDLV3 for the as requested by BPL, and that you be undertaking follow-up for possible infection with hepatitis viruses.
Yeah, I would have explained to the patients why they were having to have these extra samples taken. I'm not sure that this is the 8Y trial, because as far as I know, the 8Y trial, we were only taking samples for liver function tests.
For the sake of completeness, I don't think it answers what you don't know, Dr. Shirley, but we'll just look at BPLL 306186_002. So this is an internal memo dated the 10th of March 1986. I'm not suggesting you would have seen it at the time, Dr. Shirley, but it's recorded as an interim report on surveillance for non-A, non-B hepatitis after first infusions of 8Y and 9A into deficient patients. And it says in the first paragraph, this is an interim collation of data kindly provided by Dr. Ritzer, Dr. Colvin, Dr. Kernoff, Dr. Hill, Dr. Daly, etc., and Dr. Shirley. So you did supply data about your patients and whether there was any indication that they were developing non-A, non-B hepatitis to Dr. Snape as part of this study, I think.
Yes, as part of the 8Y study. What I'm saying is that previous document you put up where there were also bloods being taken for other hepatitis viruses and HTLV3, I wasn't aware that the 8Y trial took those other blood samples, so I can't say whether that previous document referred to the 8Y trial or to something else.
I understand. We can take that down, thank you, Shomik. Now, in your statement, you say you recall only one patient at Frimley Park being infected with HIV, but you say that there could have been others who were diagnosed at their reference centre. And just so that I understand that correctly, we'll come on to the one patient who you know was infected in a few moments. You can't, as I understand it, exclude the possibility that patients were infected with HIV as a result of their treatment at Frimley Park, but whose diagnosis was picked up by their reference centre rather than by you. Is that correct?
I only know of one patient that was infected by the treatment I gave at Frimley Park Hospital. There are other patients who were sent to me from their reference centres who had already been diagnosed with HIV.
Now, I want to ask you about that one patient who I'm going to refer to for reasons I know you understand as Mr. AJ. I'm not going to go through every aspect of his care and treatment, and you have provided a witness statement in response to Mrs. AJ's statement, which deals with a number of matters. But I do want to ask you some questions about it, hopefully without going to too many of the underlying documents. If you need to see any of the underlying documents, Dr. Shirley, please indicate, because we do have them available. This was a patient registered with Oxford Haemophilia Centre as their main reference centre, is that right?
That's correct.
And it was a patient with mild haemophilia A who'd had treatment on only 3 occasions between 1968 and 1971. So they were. He was a patient who had been minimally treated.
There was a question over what level of haemophilia he had, because his factor VIII levels, as measured in the laboratory, tended to be lower than one would expect from his clinical course. So he was actually thought to be a moderate haemophiliac, not a mild haemophiliac. And I would like to say at this point that I have always remembered this patient, because I have always felt very sorry and guilty about the fact that he developed HIV as a result of the treatment that I gave him.
Okay, thank you. This was a patient who presented at Frimley Park on the 17th of December 1984. And the significance of that date is obvious. It's a week after the meeting at BPL we've been looking at. It postdates at least the date of the draft of the AIDS advisory document. Is this right? He was treated first of all with cryoprecipitate, and then over the following days treated with concentrates, not commercial concentrates, NHS concentrates, on several occasions.
That's correct.
Is the fact that he was treated with NHS concentrates rather than commercial concentrates anything other than the luck of the draw of Tooting, so to speak, or the bad luck of the draw of Tooting? That's what Tooting sent? Or was there a conscious decision on your part by December 1984 not to use commercial concentrates?
I think I probably was trying to avoid using commercial concentrates because of the much higher number of patients that were infected with HIV as a result.
And the record suggests that he was treated with more than one batch, and that the batches included, as well as BPL products, a Scottish product. Do you know why that was the case? Was it common to receive Scottish products from Tooting?
I don't remember receiving Scottish products from Tooting. As far as I remember, we generally got BPL products. With regard to the batches, it was a question of what we were sent from Tooting.
Now, why was it that this patient was not treated in the first instance with DDAVP, given that was the recommendation from UK HCDO in June of 1983?
Because for the type of bleed that he had, it was known that DDAVP would not have increased his factor VIII level to what was the recommended treatment level for the severe muscle bleed that he had.
And when you say that was known, what was the basis for that knowledge?
Well, DDAVP generally would increase the factor VIII level by a small amount. It increased the factor VIII level much better in von Willebrand patients than it did in haemophilia patients. And for somebody like this patient who had a factor VIII level of somewhere between 1% and 5%, when you're needing to get the factor VIII level up to over 40%, you're not going to achieve that with DDAVP.
Now, why, having started with cryoprecipitate, would you not continue with cryoprecipitate for a longer period of time, given that it was a safer product in terms of the risks of viral transmission?
It's because the factor VIII levels that were being achieved with cryoprecipitate weren't reaching the level recommended for the treatment of his severe muscle bleed. And if the bleed wasn't stopped, then there was a very high risk of permanent disability.
Given that you knew by this time, at least, of the risk of AIDS associated with concentrates, albeit that your understanding was that the risk was more greatly associated with commercial concentrates. Did it not occur to you to contact Dr. Ritzer at the as the consultant at the reference centre where the patient was registered to seek any kind of advice?
No, I didn't. I was going by the guidelines in the Haemophilia Centre Director's Handbook, and my understanding was that there was a very low risk of contracting HIV from factor VIII concentrates and NHS factor VIII concentrates.
Did you tell this patient of the possible risk of AIDS from the receipt of concentrates?
No, I didn't.
Do you think you should have done?
In hindsight, yes, I think I should have done.
If you had been in receipt of the AIDS advisory document that we looked at, the 14th of December document, by this time, do you think your treatment of him would have been different?
Yes, I think I would have attempted to get hold of heated concentrate.
Do you agree that a system which led to you treating this patient in late December 1984 in ignorance of what the reference centre directors had by now decided was the right course was a system in which something had gone fundamentally wrong?
I think it was a system that reflected what was available at the time. We didn't have the quick communication possibilities that we have nowadays.
You had, and this is, when I say you, I'm not talking about you specifically, Dr. Shirley, but phones existed.
Yes.
Materials can be sent out speedily by post. They don't have to wait around for days. There are means of communicating, albeit not with the same instantaneous ability that we may have nowadays. Do you think that the reference centre directors should have done more to ensure that directors such as yourself were better informed as soon as they knew of the greater risk from NHS concentrates?
Yes, I think they should have. They sent round the AIDS advisory document. It was drafted on the 14th of December. Whether it went into the post that day, I don't know. It was a Friday. The earliest I could possibly have got it would have been the Monday, and it might have been later because of Christmas post, and then it would have to go through the hospital postal system to get to my desk. So for most documents sent by post, there would be a 2 or 3 day delay before I had them on my desk.
Now, as a result of that treatment, this patient was infected with HIV, and I'm going to ask you to look at one document from his records. It's WITN 3901013. Oh, no. No, I think that's right, sorry. We can see it's a letter dated the 6th of August 1985. And if we look at the 4th paragraph, please, Shomik. He has had no symptoms of a recent flu-like illness. We're slightly concerned that this may be in relation to some viral infection. That refers to the findings set out earlier in the letter. We must, however, also keep in mind the possibility of the HDLB3 virus being present in this gentleman and causing this problem. We've therefore arranged for him to have, amongst other things, an HDLB3 test. This was not mentioned to him purely that we were looking for some underlying viral infection, We have taken the necessary precautions here and do not think that the patient should be alerted until we have evidence that this is necessary. And it's sent out by a doctor who's described as senior house officer to you. This patient was tested for HTLV3, therefore without his knowledge and consent, wasn't he?
That's correct.
And as I understand your statement, that was the approach that was taken more generally to the testing of your other patients for HTLV3. They were tested without their knowledge and consent.
Yes.
Why?
Because at that time, patients were having trouble getting things like life insurance, travel insurance, if they mentioned that they had had a test for HTLV3, whether or not the result of that test was negative. And we were worried that if patients were told that they were being tested for HTLV3, they wouldn't be able to get insurance, because they'd have to answer the question, have you ever had a test for HTLV3? And then the insurance companies would have refused to insure them.
Was that your decision to test patients without their consent for HTLV3, or was that the hospital's decision?
As far as I can remember, it was the hospital's decision.
Would you accept that by proceeding in that way, in terms of the insurance concern that you raise, you were actually putting patients in the position of unwittingly misleading their insurers, which could invalidate any insurance subsequently obtained?
Yeah, it's a very difficult situation, isn't it? You're sort of between a rock and a hard place in deciding what's the best thing to do.
Were other tests, hepatitis B, hepatitis C in due course, or other tests, performed without patients' knowledge and consent?
No, I mean, when this particular patient developed signs of possible hepatitis in March 1985, he was told that he was being tested for viral infections which could cause hepatitis. And he was told when we had the results that he had got non-A, non-B hepatitis.
So the approach that you took, or the hospital took, to not telling patients that they were being tested was exclusively in relation to HTLV3, was it?
Yeah, that's right. There was a lot of debate at the time about whether patients should be told that they were being tested for HTLV3.
We can take the letter down, Shomik. This is August of 1985 in relation to this particular patient. Do you recall why there had been no steps to arrange the testing of your patients earlier than August 1985?
Because I didn't think that the patient would have contracted HIV. I think that was the reason that he wasn't tested sooner. I think it was because during 1985 it became more widely known that quite a few haemophiliacs had developed HIV as a result of being given British blood product, and that then we were advised to start testing our patients for HIV.
We'll just look at one further document in relation to this patient. WITN 3901015, please, Shomik. So So this is a letter which you wrote on the 28th of August 1985 to Dr. Ritzer. We can see from the first paragraph that it follows a telephone discussion you've had with Dr. Ritzer. You set out matters of history, and then if we go on to the second page, if we look at the second paragraph on that page, as a routine, we took blood to test for anti-HTLV3 antibodies since we're trying to do this on all the haemophilia patients who attend for follow-up. I enclose a photocopy of the results we've received from the Middlesex. As you can see, they feel that these results suggest recent seroconversion. So is this right? By August of 1985, you were endeavouring to test all your haemophilia patients for HTLV3?
Yeah, I think by then we were being advised that we should test all our patients. Now when I say being advised, that would have been by the UK Haemophilia Centre Directors Organisation.
Now, you were here at the end of August writing to Dr. Ritzer to tell him that this patient's HTLV3 result was a positive one. You didn't tell the patient for another few weeks. Why was Dr. Ritzer being alerted before the patient? Was it not imperative to get the patient in, not least because of the risk of infecting partners?
I think I probably left it until his next scheduled outpatient appointment.
Do you accept that that ran a risk that in the intervening period the patient could, this is as a matter of principle rather than relating to the specifics of the case, could have passed on an infection to their partner?
I suspect part of it may have been that I didn't really know an awful lot about HIV because it wasn't something that I came across very often. I had a very busy outpatient clinic. It was difficult. It was difficult to fit in patients at short notice. There wasn't a specific haemophilia clinic. I saw the haemophilia patients in the same clinic as I saw all the other haematology patients. And with a laboratory test, you get a positive, but you always have to confirm it on a repeat test in case it's a false positive. So I probably didn't feel it was imperative to get him back early.
In terms of the subsequent care and treatment of that patient or any other patient infected with HIV, your statement suggests that you were not involved with ongoing treatment of HIV. That was the responsibility of the main centre. Is that correct? Is that how matters were arranged?
Yeah, that's correct. So patients would either be managed by somebody at their main centre who was a specialist in HIV, or patients at Frimley Park were managed by a consultant who subspecialised in HIV.
Now, when a test for hepatitis C became available, you were, I think, involved in arranging for your patients to be tested. And we can see, if we look at a couple of documents, HCDO 40119_051. This is a letter, it's between the Public Health Laboratory Service and Colindale and Miss Spooner at Oxford, but it says, I gather Dr. Shirley is presently routinely screening her haemophiliac patients for anti-HCV. And then if we look at one other document, HCDO 40119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119_053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053, 119:053 we can see this is what triggered the letter. You've sent hepatitis survey reports for patients who've tested hepatitis C antibody positive to Oxford. And if we go over the page just by way of example, we don't need to look at all the details. We can see there a patient, if we look at the top of the page, a few lines down, approximate date of onset of hepatitis picked up on routine screening. And if we go down the page towards the bottom table, we can see there in the table it says hepatitis C, ABS positive, 19th of February 1991. So, and there are a few further results enclosed with this document. Is it right to understand from this that certainly by the early part of 1991, you were routinely screening for hepatitis C your haemophilia patients?
Yes. Sorry, can I just go back to the HIV?
Yes, of course.
With regard to testing and counselling patients, I work closely with the consultant microbiologist, and I was guided to quite a large extent by what she recommended for the testing of patients who might have HIV.
Just to return then to hepatitis C, do we correctly understand from these documents that in early 1991 you were routinely testing your patients for hepatitis C, a test now by that time being available?
Yeah, I think the Haemophilia Centre Directors Organisation was asking all the Haemophilia Centre Directors to do this.
And as far as you can recall, were you arranging for all of your patients to be tested, or all of your haemophilia bleeding disorder patients to be tested for hepatitis C?
Those that had no record of having been tested.
And was that undertaken with the advanced knowledge and consent of the patient?
Again, it's not something that I can remember, but I mean, I usually told them at their outpatients attendance what we were taking, what tests we were taking their blood samples for.
Did you have any involvement thereafter with the treatment of any of your patients for hepatitis C, for example, with interferon?
No, I didn't.
Were there arrangements in place for referrals to liver specialists for patients who were infected with hepatitis C?
Not at Frimley Park. Not for my haemophilia patients. I would have told their main centre what the result was, and I would have expected them to do the referrals because they had the facilities in place.
Do you recall anything of your involvement with the hepatitis C look-back programme in the 90s?
Yes.
What can you tell us?
I remember we had to do a hepatitis C look-back, and we had to identify batches of product that had been used for patients. So we had to go through the blood transfusion records, the blood bank records, to see whether any of the batches that had been identified had been used for patients at Frimley Park Hospital.
And do you recall whether there were many or any patients identified through that process who were then tested positive for hepatitis C?
I can't remember.
Just going back to the question of risks of HTLV-3 AIDS and what was available by way of information and guidance in 1984, you've said in your statement you wish you'd been given more guidance from UK HCDO and the Blood Transfusion Service about treatment and products. What type of advice or guidance would you as an associate director with a practice ranging across a wide range of haematology, as you've described, what sort of advice or guidance would you have found most beneficial, do you think?
I think, as far as I can remember, that December 1984 document was the first time that we were given any guidance on what product we should use in what type of patient. And I think if we had had that sort of guidance issued through the 1980s, it would have been easier for consultants to know that they were giving the right treatment. And also, I think it would have enabled consultants like myself to put pressure on the regional blood transfusion services to give us certain types of product.
So I know at the time I've pretty much come to the end of my questions for Dr. Shirley. If we could take the lunch break now and invite recognised legal representatives of core participants to send over the course of the lunch break to me and Mr. Bucra any questions they would wish us to consider arising out of Dr. Shirley's evidence, that would be useful.
Well, we'll do that in a couple of minutes, within which I want to ask you something which arises out of the evidence you've given. You were talking about being between a rock and a hard place. You remember that?
Yes.
And you were describing that the advice that you'd had from the UKHCDO was to test every patient that you saw who had haemophilia and test them for HIV, HDLV3.
Yeah. Yes.
So this was advice that was widely circulated and widely understood from the UKHCDO.
As far as I can remember.
The policy that the hospital adopted for anyone who was given such a test was not to tell them that they were being tested for HIV, HDLV3 infection.
Yes.
So you're following a recognized protocol by not saying. You're following a recognized protocol by testing. The reason that you understood the hospital was saying don't tell the patient, because that's what you would normally want to do. It's what you did in other cases. You told us earlier you told your patients what you were testing them for.
Yes.
So you want to tell the patient, but you don't because the hospital's view is it's going to affect or might infect their insurance.
Yes.
Did it ever occur to you, or for that matter, those who were in the similar position that you spoke to, that insurers were very likely to know that the general recommendation from the doctors' organisation was that every haemophiliac should be tested for HIV, and therefore they would naturally assume that if you happen to have haemophilia, you would be testing for that, or tested for that particular condition?
I don't think that ever crossed my mind. I didn't think about what access insurers had to protocols or it wasn't a protocol as such. It was a request that we test. It never entered my head that the insurers would have had knowledge of the UK Haemophilia Centre Directors Organisation asking Haemophilia Centre directors to test their haemophilia patients for HIV.
Because there'd be no secret about that advice to doctors from the UKHCDO, would there, as far as you know?
As far as I know, but I don't know how many people knew about the organisation.
And if it had occurred to you, you said right towards the end of your evidence that you would, in other respects, you might have been in a position to put pressure on the local blood supply services to provide different product. And so you're describing the position of a consultant occasionally being able to apply pressure to improve services or question practices. You would have been in a position, do you think, would you, to have raised it with the hospital saying, well, surely everyone knows that if you happen to be someone who suffers from haemophilia, that you're likely to be tested. Can we have a different approach here? Something along those lines. I mean, obviously, it didn't occur to you, but I mean, do you think it would have done if you'd known?
Yeah, I mean, I did have discussions with the consultant microbiologists about whether we should or should not tell patients that because it wasn't just haemophilia patients, obviously, that were being tested for HIV. And I did have discussions with the consultant microbiologists about what we should be telling the patients about the testing for HIV. And I do remember that the general consensus was that we would tell them if they tested positive, but not if they tested negative.
Now, by the general consensus, there are two people in this conversation that you're describing. Who formed the general consensus? Do you remember?
It was the sort of thing that was discussed over lunch amongst consultants at the hospital, because the gastroenterologists and other specialists, other physicians, would also have had patients that they needed to test for HIV.
And so this is a matter of general discussion, which, but the hospital itself had the policy, you say, or are you referring there to the outcome of this general discussion?
The hospital wouldn't have had a written policy. The consultant body would have had a view on how to go about HIV testing of patients.
I see. So this was really a collegiate approach that you were taking?
Yes, I think so, yes.
Yes, well, thank you very much. That's very helpful. Well, we'll take a break now till 2:05. 2:05, if you
Okay,
please.
thank you.